Hey everyone, let's just dive right into this explainer. Today, we're going to frame ray tracing not as some abstract physics concept you left behind in undergrad, but as the fundamental skill required to absolutely ace the OCAP optics section, and really, to deeply understand clinical ophthalmology. I want you to stop thinking of optics as just a series of memorized equations. As an ophthalmologist, optics is literally your normal anatomy and physiology. When you place a 20 diopter lens in front of a patient's eye for an indirect exam or calculate an IOL power for cataract surgery, you are physically manipulating these exact rays. If you don't understand how light bends, you can't truly grasp how a refractive error develops or how your surgical interventions actually fix it. So today, we're building true long-term clinical mastery of ray tracing. Let's get started. Here is our clinical optics roadmap for today. We'll start with Section 1, the OCAP imperative. Then Section 2, the 3 golden rays. Section 3 is decoding real versus virtual. Section 4, the plus lens trap. Section 5, the minus lens curveball. And finally, Section 6, refractive index board pearls. All right, Section 1, the OCAP imperative. Let's quickly establish the why behind ray tracing and why this matters so much for your written qualifying exams and your daily practice. Mastering these 4 properties will allow you to answer practically any optical system question the boards can throw at you. And more importantly, it directly dictates patient outcomes. Let's break down the clinical importance here. First, the exact location of an image. Why do we care? Well, because if that image location doesn't land perfectly on the photoreceptors of the macula, your patient complains of blur. Simple as that. Second, whether an image is upright or inverted. Think about when you put on your indirect ophthalmoscope and hold up a condensing lens. The retina appears flipped, right? You need to understand the optics of why that happens so you can accurately localize a retinal tear. Third, the real versus virtual status. This tells you exactly where the physical light is actually traveling versus where the patient's brain perceives it to be. And fourth, precise magnification or minification. Think of a patient with unilateral aphakia after trauma. If you give them a thick plus lens in their glasses for just that one eye, you create severe magnification. That leads to anisoconia, which is a difference in image size that the brain just cannot fuse. Ray tracing is the diagnostic tool that reveals the mechanics behind every single one of these clinical realities. Moving on to Section 2, the 3 golden rays. Let's look at our normal anatomy and build our mental model using a standard thin plus lens. I want you to picture the absolute tip of an object out in space. In reality, it's got an infinity of light rays bouncing off of it in every possible direction. But guess what? We don't care about the infinite rays. We only care about the defining rays that interact with our optical system. These 3 limiting rays represent the core anatomy of ray tracing. First up, trace the nodal ray. This is the undeviated anchor of our whole system. It shoots straight from the object's tip, goes perfectly through the optical center of the lens, and just continues on a perfectly straight line. Next, trace the primary focal ray. This one passes through the front or primary focal point. Because of how the lens bends it, it exits perfectly parallel to the optical axis. Finally, trace the parallel ray. It comes in flat and parallel, hits the lens, and gets bent directly through the secondary focal point on the other side. You absolutely need to memorize this exact behavior. Create a crystal clear mental model of how these 3 rays act, because knowing how they move lets you solve literally any optical puzzle. And just a quick note, while we're describing all 3 here, any 2 of these rays are actually sufficient to accurately map the system. So the crucial takeaway here is that finding the exact intersection of these rays is your ultimate goal. Where those rays cross, that is the exact location of the newly formed image. Connect this to your clinical physiology for a second. In a perfect emmetropic human eye, that crisp intersection lands exactly on the fovea centralis. When it doesn't, like when the intersection falls in front of the retina or theoretically behind it, you've got a refractive error. That lost intersection is the literal pathophysiology of blur. Okay, Section 3, decoding real versus virtual. Let's get into the ultimate diagnostic rule. We need a rock-solid mental model here. I can basically guarantee you will see a board question trying to trick you on this exact definition, so lock this into your brain right now. This is a classic board trap that constantly trips up residents. Don't waste time memorizing 100 complex examples. Just remember this really simple heuristic. Same side equals real, opposite side equals virtual. What exactly do I mean by that? Well, look at your object. Are the physical light rays on the same side of the lens as the object itself? If yes, the object is real. Now look at the image that forms. Did the physical light rays actually travel to the side of the lens where the image formed? If they did, it's a real image. But if the image is sitting on one side and the physical light rays are completely stuck on the opposite side, that image is virtual. And this brilliantly illustrates our golden rule of optics. It's an incredible pattern recognition strategy for the exam. If your pen is drawing dashed lines, you are looking at a virtual image or object. Why do we even draw dashed lines in the first place? You have to understand the physiology of the observer's brain here. The human brain assumes that light always travels in a perfectly straight line. So when diverging light hits our eye, our brain artificially projects those rays backward in a straight line to try and make sense of them. Those dashed lines represent that imaginary retroactive projection. Because the physical light rays never actually travel back there, the image is virtual. Dashed lines mean imaginary pathways, which immediately means a virtual image.
Let's move on to Section 4, the plus lens trap. We're getting into some advanced clinical scenarios now. Let's test your clinical reasoning by placing a real object very close to a thin plus lens. This is a classic OCAP setup. Let's frame it as a realistic scenario. You're holding a plus lens very close to a patient's cornea. The object is pushed right up close to the lens, sitting completely inside the primary focal length. I want you to pause for a second. Visualize those 3 golden rays we talked about. Take a moment to lock your answer in. How do those rays behave when the object is pushed up this close?
Okay, let's trace the rays together. See how the parallel ray bends through the secondary focal point, but the nodal ray goes straight? Notice something alarming here? The physical light rays passing through the right side of the lens are actually diverging. They're spreading further and further apart. The biological eye cannot focus diverging rays, and they will literally never intersect in physical reality on that side. So what do? We trace those dashed lines backward to the left side of the lens. They intersect way behind the original object. Because the image and its defining physical rays end up on opposite sides of the lens, boom, we have a classic virtual image. What you've just created here is the exact optical model for a stand magnifier, like the ones used in a low-vision clinic for patients with macular degeneration. It creates an upright, magnified, virtual image.
All right, listen up because here is a massive OCAP pearl. Do not confuse real and virtual with upright and inverted. They are completely different concepts. Upright simply means the object and the image are on the same side of the horizontal optical axis. Even if both the object and the image are pointing completely downward below the axis, the image is still considered upright relative to the object. Inverted means they're on opposite sides of that horizontal line. Think about looking at the fundus with a 90-diopter lens at the slit lamp versus looking through a direct ophthalmoscope. You've got to keep your vertical axis logic, which defines real versus virtual, completely separate from your horizontal axis logic, which defines upright versus inverted.
Next is Section 5, the minus lens curveball. This is all about navigating pathological optics, and it frequently catches residents totally off guard on test day. So what's really fascinating about the anatomy of a minus lens is how this single structural change completely alters the trajectory of our golden rays. And honestly, it's fundamental to treating your myopic patients. In a plus lens, the primary focal point is on the left, and the secondary is on the right. But in a minus lens, they flip. The secondary focal point is now on the left side of the lens, and the primary is on the right.
Let's inject a clinical scenario for some active recall. Think of a -10 diopter myope looking through their really thick glasses. What happens to the image of the world around them? Trace the rays in your mind. Think carefully about how that swapped secondary focal point alters the path of the parallel ray when it actually hits the lens.
So when the parallel ray hits a minus lens, it diverges, but it diverges on a very specific path, as if it originated from that secondary focal point sitting over on the left side of the lens. Just like with our magnifying glass trap earlier, the physical rays exiting the right side of the minus lens are spreading apart. So once again, our brain uses dashed lines to trace backward to the left to find that interception point. We use dashed lines, so immediately we know it's a virtual image. It sits on the same side of the horizontal axis, so it's upright. But crucially, this intersection happens closer to the axis than the original object did. This results in an upright, minified, and virtual image. This right here is exactly why your highly myopic patient's eyes look physically smaller to you when you're looking at them across the exam room through their heavy minus spectacles.
Finally, we reach Section 6, refractive index board pearls. Let's talk about the environmental shift and end with a slightly more advanced concept. Up to this point in the explainer, we've assumed perfectly uniform refractive indices, air on the left, air on the right, both with an index of 1.0. But what happens if we introduce a mismatched index? Think of a real clinical case. An eye filled with silicone oil after a complex retinal detachment repair, or maybe replacing a crystalline lens with a synthetic IOL in a fluid-filled eye. We're no longer in the dry physics lab here. We're in the operating room. A biological environment like this completely warps the optics.
Okay, Here is your visualization and memory trick for this board pearl. I want you to imagine the denser, thicker fluid physically grabbing the nodal point and powerfully pulling it toward itself. At the exact same time, it stretches the focal length on that side, extending it out like a rubber band. A higher refractive index pulls the nodal point and stretches the focal length. Memorize that.
So imagine you're sitting for your written boards, and this exact scenario pops up. You have a lens, the left side is air, but the right side is suddenly filled with water. I'll give you a second to think. This is a totally classic board question. If you know the rule we just talked about, you don't need to do any complex math. Just walk through the anatomical shift in your mind. Where does everything move?
Let's walk through the physical consequence. Because the water is on the right, the nodal point gets pulled to the right. The secondary focal point gets stretched further to the right. These combined shifts force the intersection of our defining rays to happen further back. Consequently, the entire image moves in that exact same rightward direction. Now, what does this mean clinically? Well, if the image moves further back, it means the focal point is pushed behind the retina. This creates a hyperopic shift. The patient suddenly needs more plus power. This is exactly what happens clinically when fluid dynamics change in the eye, and understanding the directional shift is exactly why you can diagnose it perfectly.
You now have the fundamental mental models to confidently tackle these problems. But listen to me carefully as an educator. You cannot move on to advanced clinical optics until these fundamentals are second nature. You have to prove to yourself you've mastered these concepts before progressing. So it's time to put that knowledge to the test with some active recall. I want you to go take quiz 4 to really solidify this foundation. And I'll leave you with this final rapid-fire question to permanently engrave this into your clinical arsenal. When you see dashed lines, what are you looking at? You got it, a virtual image. Understanding the deeper why behind these dashed lines, these focal points, and these golden rays is exactly what separates a technician who just inputs numbers into a machine from a master clinician who truly understands the human eye. Master these rules, trust your ray tracing, and you are going to absolutely dominate the optics section. Keep studying hard, and I will see you in the next explainer.